Thank you. Well, it's an honor being with you today. I wish I could be there in person, but in this Zoom age over the last 20 months, what we've learned is that, when you have a 30-minute or an hour presentation, Zoom seems to be the easiest way. With that said, I honestly was planning to be there, but there was a meeting 2 days ago that was canceled or moved to virtual, and that ended my aspirations to be there. But anyway, I'm with you virtually. It is an honor, and I'd like to just sort of go over some things going on in oral health from a 30,000-foot view. I have nothing to disclose as far as conflicts of interest. What I want to do is quickly tell you about the Public Health Service. I'll talk a little bit about COVID, of course. I'll talk about what used to be the second ever Surgeon General's report on oral health. I'll talk about some issues in oral health over the next year, and of course end with talking about veterans. So first, I want to thank all of you because I've gone around the country. I've spoken at a lot of state meetings, and I believe this is my 24th State Oral Health Coalition meeting. And yes, for the last 20 months, most of them have been virtual, but I did go to a number of them in person, and that picture is one from the Kansas Oral Health Coalition. But I do believe, many of the things that we talk about at the national level really get implemented because of state oral health coalitions, especially those coalitions that have non-traditional stakeholders, non-dental stakeholders. So thank you all for what you do to advance oral health in America. So a little bit about the Public Health Service. Our motto is in officio salutis, which we translate to mean in the service of health. We're one of 8 uniformed services in the United States: Army, Air Force, Navy, Marines, Coast Guard, National Oceanic and Atmospheric Administration, and the new U.S. Space Force being the others. We were formed in 1798. We're led by the nation's doctor, the U.S. Surgeon General, and operationally led by the Assistant Secretary for Health, who is currently Dr. Rachel Levine, and our Surgeon General is Vice Admiral Vivek Murthy. We dentists in the Public Health Service serve alongside veterinarians, physicians, nurses, environmental health officers, and many other different health disciplines and allied healthcare personnel. The picture here on the left is a picture of a deployment. We're deployed across the world, actually, in response to different public health events, including natural disasters such as hurricanes. And we've been deployed extensively throughout this pandemic. Dentists in the Public Health Service serve primarily in 3 different departments in the federal government. Within the Department of Justice, we serve in the Federal Bureau of Prisons. Within the Department of Homeland Security, we have dentists serving both in the U.S. Coast Guard at over 24 stations around the country, and at over a dozen Immigration and Customs Enforcement health stations. We primarily, though, serve in the Department of Health and Human Services through such agencies as the Centers for Medicare and Medicaid Services, the National Institutes for Health, Centers for Disease Control and Prevention, Indian Health Service, which is where I serve, the Health Resources and Services Administration, and lastly, the Food and Drug Administration. So that's a little bit about who we are. At the very end of my presentation, I'll have a website that you can go to learn more, but I'll just tell it to you right now. It's usphs.gov. Oops, going backwards. So let me talk a little bit about COVID. So first of all, prior to March of this year, we had a number of states authorize dentists and dental students and hygienists to administer the COVID vaccine. We had 24 states that authorized that, and that was either through state board temporary rules, through legislative action, or through executive orders by governors. And in addition to that, we had some states that expanded that to allow dentists to administer the influenza vaccine last year. The game changer kind of happened in March of this year, 4 months after the vaccines became available, when the federal government authorized the Seventh Amendment to the Public Readiness and Emergency Preparedness Act, or PrEP Act, which authorized all dentists and dental students across the nation to administer the vaccine. Of course, we're all bound by our own state licenses, so it still really is up to the state boards and so forth. Over the last few weeks, you've heard a lot about vaccinations in children. I just want to show you this table. The Pfizer vaccine has now been authorized for children 5 to 11 years of age. Moderna and J&J are not. So the same with 12 to 17-year-olds, it's Pfizer only. And then, of course, all three for 18 and older. Also, hopefully you have received your booster. Here's a lot of information, but basically if you got the Moderna or the Pfizer, you should get the booster 6 months after that second dose. If you got the J&J or Janssen, you should get it 2 months after that first and only dose. The Moderna and J&J are for 18 and over. Again, the Pfizer can be given 5 and over. Now, when I sent the original slides to you, we were in the bottom, we were in a downslope on our second largest peak in cases. But as you can see, and I pointed an arrow to this, we're starting to see a little upsurge here, which is a little troubling. So as of November the 8th, we have 134,000 cases, a 7-day moving average, which is the average over the last 7 days, of 73,000. That is down from this peak back in early September of 163,000. But again, what's troubling is all the rest of these peaks kind of went straight down. This one's starting to go back up. This is the so-called winter surge that you've been hearing about. We have not yet seen that with deaths or hospitalizations, maybe a little bit with hospitalizations, but if you remember, hospitalizations follow cases by about 2 weeks and deaths follow that by about 2 weeks. So we should see a little surge there as well. One of the impacts we've seen from an oral health perspective are the the return in children's dental services for children with Medicaid. So if you look at this graph, the top line is the average number of dental services provided each month to children with Medicaid. And this was for the 3 years prior to the pandemic year. And you can see on average, there's around 3.5 to 4 million services. The dark blue line there is dental services provided since the pandemic. So you saw this huge drop off. Of course, we saw that in everything as we shut down routine services. But, by June, July, most of the dental services across the country had returned almost to normal, maybe about 95% of normal. Whereas children's dental services on children with Medicaid still is low. It's about 79 to 80% of its normal delivery. In addition to that, we saw about 10% of dentists disenroll from Medicaid since the pandemic began, and that's really troubling. And 25% were enrolled at the beginning of the pandemic. So there is certainly an impact on oral health, and I think we're continuing to learn more about that. So now let me shift gears and talk a little bit about the first Surgeon General's report on oral health and the second one. So this is a picture of the first one. It came out in 2000, and it had as its major message that oral health meant much more than just healthy teeth, and it was integral to the overall health and well-being of all Americans. So this report, like all Surgeon General reports, are available on surgeongeneral.gov. This one was about 300 pages or so. Surgeon General, the former Surgeon General Jerome Adams, commissioned a second Surgeon General's report, which was initially going to be released on the 20th anniversary of that first one. And we had a listening session, and there's the picture on the left, the Surgeon General's right in the middle, and I'm right next to him. And on the right, that's him speaking at this listening session that was attended by hundreds of key stakeholders from across the nation. Well, not surprisingly, and this is not unusual for Surgeon General reports, the report, when we had a change in administration, we also had a change in Surgeons General, and the report now is still going to be released, but not as a Surgeon General's report. It will be released as a report from the National Institutes of Health, the National Institute of Dental and Craniofacial Research in particular, which is one of the 27 NIH institutes. The content of the report stays exactly the same. The title stays the same. It's called Oral Health in America, Advances and Challenges, and it should be released before mid-December of this year. There were about 400 contributors from across the nation, probably many from Pennsylvania even. And certainly we had the voice of the National Oral Health Coalition as well. But NIDCR was in charge of writing the report. Surgeon General reports are not written by the Surgeon General, they're written by different agencies. So NIDCR did write it, or oversee the writing. Again, we had 400 contributors. But if you have any specific questions, especially once the report is released, you can go to Oral Health Report at nih.gov with your questions. So we don't refer to it as a Surgeon General's report anymore. We just say the NIH report entitled Oral Health in America. So I want to talk about three big issues. First is medical dental integration. This is a growing movement. It's been growing for 20 years, but it's important to understand that it is a multi-directional process where it's not just integrating oral health into overall health, but overall health and oral health. And I'm going to give you these numbers again in a different format, but these are some numbers I want you to remember. And I think the graph will actually help. There are 64.7 million Americans each year that don't see a dental or medical provider. That's that white circle. There are 121.2 million that see both a dental provider and a medical provider each year. There are 112.3 million, though, that see only a medical provider and not a dental provider. So that gives us some unique opportunities to have medical practitioners doing oral health assessments, doing fluoride varnish applications, doing nutritional counseling, and talking to parents and children about the importance of oral health, and perhaps even doing other things. Like I know Wisconsin and Minnesota both have projects ongoing, and the Indian Health Service is about to do this as well, where we have medical practitioners administering silver diamine fluoride in high-risk populations. But the number I want to concentrate on is this 28.2 million. I'm not sure if that shows up well when you look at it, but there are 28.2 million Americans that see a dental provider each year, but not a medical provider. And this is really important because we know that screening for chronic disease is something that oral health professionals can do and should do. And I'll give you some statistics in just a minute, but what's even more important are some of these numbers under that. So there are 7 million children between the ages of 6 and 17 that see a dental provider, but not a medical professional each year. And especially when you get a little bit older, around ages 11 and 12 and up into the teens, one of the really important aspects of this is HPV. And we know that there is a vaccine available for HPV. It can be given as early as age 9, ideally given around 11 and 12. And we also know that HPV is in our territory. HPV attributed oropharyngeal cancer is the top HPV attributed cancer, surpassing cervical cancer. So in the very least, oral health professionals should be educating parents and teenagers about the prevalence of HPV or oropharyngeal cancer and the availability of the Gardasil 9 HPV vaccine. There are also 1.1 million children under the age of 6 that see a dental provider each year, but not a medical provider. And this is important because we know that there are a lot of kids that fall off their immunization schedule. So there are 1 in 5 children under the age of 2 that fall off their DTP immunizations. There are 1 in 10 that fall off their MMR immunization schedule under the age of 2. So again, this is a great opportunity in the medical history to ask parents about whether their kids are up to date on immunizations, maybe even have a cheat sheet in the dental operatory to know what the vaccination schedule is. I mentioned there are a lot of undiagnosed chronic diseases. There are 11 million undiagnosed hypertensive, 7.3 million undiagnosed diabetics, many millions high cholesterol, 10 million undiagnosed with depression, and 17.7 million undiagnosed with substance use disorder. So there is an opportunity for oral health professionals to sort of think outside the box, screen patients for these and other things as well. And the ADA Health Policy Institute even says that screening for chronic diseases could save as much as $102 million per year, or $33 per patient in associated healthcare costs. Let me switch gears a little bit and talk about access to dental care now. These 2 graphs show the percentage of people with a dental visit in the last year. Children on the left side, adults on the right. And you don't have to pay attention to the 2 time periods. They're just looking at the improvements from 2 sets of data. But what I do want you to pay attention to are the different races and ethnicities. The purple or burgundy color are U.S. white, non-Hispanic whites. The teal color is U.S. Asians. The green are U.S. Hispanics. And the orange are U.S. non-Hispanic Black people. So if you look on the left, what you'll see is the group with the highest access to dental care is U.S. white children at 55.5%. The group with the lowest is 42.6%, and U.S. Black children. So there's a gap of only about 13%, which isn't that bad. It is improving if you look at the 2 sets of data there. And what's the equalizer? Well, it's Medicaid and the Children's Health Insurance Program. Now look over to the right and we'll look at adults. Again, the colors are the same. The burgundy colors U.S. whites, the teal is U.S. Asians, greens U.S. Hispanics, orange is U.S. Blacks. And again, U.S. whites have the highest access to care at 47.8. U.S. Hispanics at 27.8 have the lowest. So the gap is actually about 20%. And so, some of the differences are that, there are trust issues, oral health literacy issues, but there are also issues with insurance as well. We know that only 21 states offer comprehensive adult Medicaid dental benefits, and I'll show you a map in a few minutes. Pennsylvania, at least according to our data, is not one of those. And why does this matter? Why do I bring up race and ethnicity? It's because of this. If you look at the top, what you'll see are different disease characteristics. Caries prevalence or caries experience is any history of decay, so that's decay missing due to decay or R-field. Untreated decay obviously is active disease. Total tooth loss is self-explanatory. But if we look at differences among different races and ethnicities, what you'll see, and I put it in red font, is that Black non-Hispanic Americans and Mexican Americans suffer disproportionately from dental disease across the entire lifespan compared to U.S. white non-Hispanic people. Looking at income, same thing. Those who are, and I put it in red font again, those who are living at or below 200% of the federal poverty level, or FPL, which is currently around $25,000 for a family of 4, suffer disproportionately compared to the middle class, those who are living at or above 200% of the FPL. And sometimes those differences are as much as 3 times the prevalence, so pretty significant. So one of the other problems we have with access to care, and I'll talk about this in the next slide as well, is the maldistribution of oral health professionals. So each of these purple areas, regardless of the different shade, are counties that have been designated as dental health professional shortage areas. And you can see in Pennsylvania, I don't know how well you can see that map, but pretty much outside of every urban area in Pennsylvania, it's the counties designated as a dental HPSA. There are 60 million people across this country living in dental HPSAs, and HRSA, the Health Resources and Services Administration, estimates it would take 11,000 practitioners if we want to address this issue. We also know that state by state, there's a difference. So New Jersey has the highest density of dentists at 81 dentists per 100,000. Arkansas has the lowest at just under 41. The average is around 61, and that's where Pennsylvania is. We know also another thing that affects access to care is the cost of care. And about 10% of Americans forego dental care because of cost, which is almost double that will forego any other type of health care. I told you about Medicaid. Pennsylvania is one of those states that offer, according to our data, limited Medicaid coverage for adults. There are 21 states that do. There are 3 states that offer absolutely no coverage. And extensive means more than 100 services provided. But even the ones that are doing Medicaid, not everyone is a Medicaid provider, obviously. And it ranges from a low of 15% in New Hampshire to a high of 77% in Iowa. Pennsylvania is stuck right in the middle at 44.9%. And what we know about Medicaid providers is if they are minorities themselves, if they're women, if they're younger dentists, they're more likely to be Medicaid providers. Another factor that is affecting access is just the cost of dental school education. According to the American Dental Education Association, the average debt for our dental students is around $300,000, which equates to about $700,000 after it's paid off in 25 years. And this really drives dental students on where to practice. In fact, 25 years ago, when I was in private practice, 2/3 of professionals were solo practitioners. Now that's dwindled down to about 1/4 of dentists, and the rest are in group practices. And the dental support organizations, corporate dentistry, this graph shows 8.3%, but that was back in 2019. And I think that was an underestimate. We now believe that is somewhere between 15 and 25% of all dentists are in corporate dentistry. Now, there's some other models out there, dental therapy, which I'm sure you've heard a lot about. There are 12 states that have authorized therapy, including Minnesota in 2009, 9 states exploring it. The scopes of practice for dental hygienists have been expanding, especially in the Northwest and Southwest. Pennsylvania is in this Northeast sector, and I've pointed to pretty limited scope of practice for dental hygienists according to these data here. Another model is the expanded function dental assistant. There are 14 states now, including Pennsylvania, that, according to our data, that recognize restorative expanded function dental assistants, where dental assistants can restore the teeth that the dentist prep. And then the last model I'll talk about, in response to the dental therapy movement, the ADA created the community dental health coordinator model, and now there are 9 states, including Pennsylvania, that are actively engaged with community dental health coordinators, which are hygienists, or in some cases assistants that help coordinate care for high-risk populations, working with private practitioners and federally qualified health centers. So that's it. I know that that's a whole lot in a very short amount of time, but I hope I kind of gave you a 30,000-foot overview of what's happening. Thank you for the opportunity to speak with all of you today. Here's my contact information. Again, that usphs.gov if you would like to know more about the Public Health Service. And lastly, I just want to do a salute myself to all of the veterans in the audience and all of your friends and family that are veterans as well. I know I'm a day late, but thank you for your service and your sacrifice to our nation.